Thank you very much, and it's an honour and privilege here to speak at this amazing event. And as you said, there's so many collaborative strategies and there's so much learning to be done and cross-fertilising between our specialities and ideas. So I'm going to talk about ovarian ageing, preservation and restoration today. I work full-time as a gynaecology consultant and fertility specialist at the Lister Fertility Clinic, but I also have honorary consultant positions at Imperial College NHS Trust and and Oxford University Hospital's NHS Trust. I also work at a company called Fertility Health, which I'll just mention a conflict that I do have a small number of shares in Fertility Health. It's a femtech startup that aims to empower women by doing at-home blood analysis to check for hormonal and ovarian reserve health. So to introduce the functions of the ovary, I'm sure you're well aware, there's two main functions. First of which is the role in follicular development and the production of oocytes, which are essential, of course, in reproduction. But also, we need to think about the production of ovarian steroids like estrogen, testosterone, and progesterone. So, there's various different stages of ovarian ageing and the way that they can impact women. Of course, those younger women may well suffer with subfertility. Those that haven't completed their families or have yet to have children may suffer with either subfertility or infertility as a consequence to premature ovarian ageing. But likewise, those women who don't want children or who have completed their families already, they may suffer more from a hormonal perspective. And as you can see, there's an enormous inter-individual variation with regards to ovarian ageing. For instance, when you take the menopause, women could quite easily go through the menopause at 42, 43, or conversely 56, 57, 58. There's about a 20-year range for women as they go through the menopause. So there's a number of pathological causes of ovarian ageing, things like autoimmune disease or inadequate nutrition, prior surgery. So if you've had an ovary removed or had a cyst removed from an ovary, it can impact the rate at which that ovary ages. Certain genetic conditions like Turner syndrome or infections that can cause things like oocytes, like with mumps, can all accelerate ovarian ageing. Thyroid disease and other toxins such as chemotherapy can also have a similar impact. But the one inevitable thing, of course, is the impact of age. So when females are born, they have up to 2 million primordial follicles. As age advances, this gradually decreases to an extent where by the time women start to have periods, they have about 400,000 remaining. As time continues, the ovarian reserve continues to slowly decline to an extent where once they go through the menopause, less than 500 follicles remain. Now, not all of these follicles have the capacity to create a fetus and offspring. Only about 400 follicles will eventually develop that capability. So how can we monitor ovarian ageing or ovarian reserve? Well, historically, we've done ultrasound scans to count the number of follicles within each ovary. This is called an antral follicle count. This is a very accurate measure of ovarian reserve. But each of these little follicles produce a hormone called anti-Müllerian hormone, or AMH. And as age advances and as the ovarian reserve declines, we know that these reliably decrease. FSH, or follicle-stimulating hormone, on the other hand, we know that rises as ovarian reserve declines. So how does this translate to reproductive outcomes? As you can see, this is a study by Steiner et al. In Fertility and Sterility, which assessed the cumulative pregnancy rates after 12 months of unprotected sex stratified for age. As you can see, in women aged between 30 and 33, we've got about an 80 to 85% chance of conceiving within that time. And this decreases 10 years on, so between 40 and 44, to around 50%. So it's a significant decrease in positive reproductive outcomes. A similar pattern is also seen when assessing IVF outcomes. As you can see here, in women under the age of 34, you would expect, this is from the Human Fertilisation and Embryology Authority data, so it's nationwide data, and the pregnancy rate per embryo transfer in women under the age of 34 is approximately 40%. But looking further on, in women aged between 40 and 42, this declines to around 15%. So again, it's significantly less. But it's not just related to the egg number. Of course, we know that the egg quality also declines as age advances. And this is probably best exemplified when looking at the risk of aneuploid within embryos that are created with those eggs. As you can see, those women that are aged around 30, you've got about a 15% chance per embryo of it being aneuploid. But advance to 10 years forward, and again in 40-year-olds, they've got a 4 times higher risk at almost 60% of aneuploidy in each embryo created. So how old should women be when they attempt to start a family? Well, there was a study by Habima et al. In Human Reproduction, which did an evidence-based simulation study of 10,000 couples. And they found that couples should start attempting to conceive if they want a one-child family at the age of 32. This reduces to 27 if they want 2 children, and 23 if they want a 3-child family. If IVF is acceptable and available to them, then they could delay to 35 for one child or 31 for a 2-child family. But as a consequence to numerous societal changes and evolution, you can see that the average age of first-time motherhood continues to increase. You can see that if you look back to around 1970 or 50 years ago, the average age of first-time motherhood was about 23 to 24. But moving forward, if you look to the right side of the graph on the blue line, you can see that that age has now increased to 28 to 29. When you consider the age required to have 2-child family, you can see that women now are potentially delaying childbearing to an extent where it's going to affect their reproductive aspirations and plans. So it's unsurprising that rates of involuntary childlessness have doubled since the 1970s. But there's a number of psychological sequelae that happen as a consequence to infertility. So more than a third of infertile women suffer with depression, and they've been shown to have double the suicide risk. They've also been shown to have a reduction in quality of life, but also a decreased perception of their own femininity and lower self-esteem. It's also unsurprising that this can be quite difficult for couples undergoing quite a stressful process, and more than a quarter of couples separate after unsuccessful IVF treatment. There's also a significant potential economic impact if we think about the bigger picture. A study by Folset et al. Published in The Lancet found that a total fertility rate of 2.1 was needed to replace a generation. Back in 1961, in the UK, our total fertility rate was 2.78, but this reduced to 1.63, so almost 25% below the replacement level a few years ago. And by 2050, 151 countries are expected to have a TFR below the replacement level, and by 2100, if we're still alive due to global warming, 183 countries will be in that position. And especially we heard earlier about the average lifespan increasing, having far less contributors to support that ageing population will have an enormous economic impact. So in women beyond their reproductive years, we start to think about the impact of menopause and the overall impact on overall health. And we know that menopause can act as a bit of a pacemaker when it comes to ageing in females, because we know that it accelerates a number of other issues that can accelerate ageing in the bigger picture. We know that estrogen is heavily involved in the regulation of bone remodeling, and following premature menopause, women can have osteopenia, osteoporosis, and increased risk of fractures. Estrogen is also cardioprotective, so we know that cardiovascular mortality and stroke risk also increase. the risk of colorectal cancer also increases. So in light of all of these things, it's unsurprising that there's increased mortality and a reduced lifespan in women who go through the menopause earlier or have premature ovarian ageing. And there's also a number of other factors that can impact their quality of life. So what is there in our environment that impacts ovarian ageing and ovarian health? Well, smoking, as we've heard already, is terrible for ageing, and that's also the case when it comes to the ovary. We know that in women that have undergone hysterectomy and removal of their ovaries, when looking back at their smoking history, there's a lower follicular density with an inverse relationship seen, depending on how many pack years they had. Smokers who are aged between 38 and 50 have 44% lower AMH, so less ovarian reserve, than the non-smokers. But interestingly, this wasn't seen in women under the age of 35, suggesting that these women have better compensatory and homeostatic mechanisms to deal with the potential damage. And a meta-analysis of 11 studies has shown that smoking is an independent risk factor for accelerating menopausal age. When it comes to alcohol, we know that binge drinkers and heavy drinkers have a 26% lower AMH than regular drinkers. But conversely, in women that have a mild to moderate alcohol consumption, it interestingly appears to increase the number of non-growing follicles within the ovary. And a meta-analysis of 20 studies found that mild to moderate alcohol consumption is associated with a slightly later menopause. From a nutritional perspective, we know that a Mediterranean diet significantly improves oocyte yield in women undergoing IVF, and there's also good evidence in more than 22,000 women that it can lower the risk of infertility. Conversely, a Western diet has been shown in both animal and human studies to not be as beneficial. In fact, it's been shown in non-human primates that it can alter ovarian cycles and reduce AMH. It's also been shown to have a 44% reduction in blastocyst formation and delayed mitotic timing, suggestive that it directly impacts egg quality. And in humans, it's also been shown to be associated with infertility and a moderately increased time to successful conception. With regards to certain supplements that we can take, omega-3 polyunsaturated fatty acids have been shown that for each 1% increase in serum concentration, there's been a demonstrated 8% increase in pregnancy and live births in women undergoing IVF. And folic acid has been shown that in women that consume more than 800 micrograms daily, compared to those that take less than 400 micrograms, to be associated with a 20% improvement in live birth rates in women undergoing IVF. And coenzyme Q10 supplementation has also been shown to improve egg quality and pregnancy rates. Certain environmental toxins, we heard earlier about air pollution, and we know that inhaled airborne particulate matter has been shown to reduce fertility rates. There's also endocrine disrupting chemicals that are found in paints, lubricants, plastics, pesticides that are all associated with female infertility and an early menopause. Women with high levels of polychlorinated biphenyl have a 50% lower pregnancy rates compared to those with low levels. And in women undergoing IVF, those in the top with a top 25% body load of bisphenol A, which is found in plastics, have a more than 200% more likely risk of implantation failure. Also, when looking at female farmers in Ontario, there's been a 49% reduction in fertility thought to be related to pesticide use. Also, lead has been shown to accumulate in follicles, and this directly affects oocyte meiosis and maturation. And it's been shown that IVF outcomes are inversely related to the follicular fluid levels of lead. Finally, in things in our environment that we can do to alter ovarian ageing, we know that hormonal contraception from a meta-analysis of more than 30 studies found that previous use of an oral contraceptive was associated with a later menopause. And a similar trend was also seen for women who had a previous offspring. So this is the shout out to the company that I work with called Fertility, and As I mentioned, it's a femtech company that aims to raise awareness and try to identify women at risk of adverse ovarian hormonal health. So what happens is that the consumer goes online and they produce a virtual health assessment, and more than 300,000 women have now completed that. 20,000 of those have completed hormone at-home blood tests, and we found that just over 15% of those have a low ovarian reserve. It may well be that this doesn't ever impact these women. It may cause unnecessary anxiety, but it also may allow women to be aware of their ovarian health and age and amend their reproductive aspirations and plans accordingly. There's also an enormity of possibilities moving forwards with us looking into these women further and potentially giving them treatment to see if we can reverse any of their ovarian ageing. So what methods are there now to preserve our reproductive potential? So the main thing at present is the use of oocyte cryopreservation, or social egg freezing. And this was first reported more than 30 years ago, but it was initially used slow freezing methods, so it was associated with suboptimal outcomes due to the ice crystal formation within the eggs. However, following the development of vitrification as a cryopreservation method, the success rates and reproductive outcomes have significantly improved. Now, using this method, there is no difference in pregnancy, miscarriage, or live birth rates between using fresh and frozen eggs. And the most important fact is that the age that you freeze the eggs, the reproductive potential of that egg stays at that age, so you can reverse the ovarian clock, as it were, although there is, of course, only a finite number of those eggs to be used. We think that between 20 and 25 oocytes are needed for an 80 to 85% chance of a live birth in a woman who's 35 years old. And clearly that would be, you'd need less eggs if the lady was much younger, and conversely you'd need many more if she was much older. We've published numerous studies on this subject. Most recently, we published the largest data set in the UK on women that have frozen their eggs for social reasons. And it was 373 women. They had a median age of 38 years. They stored a median number of eggs of 8. And just less than 10% at the time of publication had returned to use their eggs. And 12 live births had been reported amongst 11 women, with a live birth rate per thaw cycle of almost 27%. Importantly, there was no live birth seen in any women that froze their eggs over the age of 40. And we know from that, and we know from the median age of 38 and the suboptimal number of eggs frozen, that women are thinking about this at the moment much too late for it to be an effective treatment option. We've done some other studies looking at this, although none of them have been published in Nature yet, like most of the speakers today. I'll just quickly talk about the top two. The top left one looked specifically at the quality of life in women that undergo this process, and we found that largely there's no negative impact, and it's something that's largely well tolerated by women undergoing the process. We did identify a small subgroup of women that found it increasingly stressful, and that was women that had been recently separated or divorced. So these require increased support when undergoing this type of treatment. And then the top right study, we looked at the perceptions, outcomes and regret following social egg freezing, and found that 91% of the women had no regrets, and a small number of women, the remaining 9%, did have some mild regret, and this was mostly perceived to be related to the suboptimal number of eggs gained. But again, this is probably because they've frozen their eggs too late. Although not often the case, as you know, from the individual variation, sometimes young women have a low ovarian reserve and they end up with a suboptimal egg number. So what else can we do? And this is something that's much more novel as a treatment option, but has a much greater number of potential benefits. And instead of freezing eggs, we could really go back in time and actually refreeze strips of ovary. This is called ovarian cortex cryopreservation. It's undertaken through it's a laparoscopic procedure under a general anaesthetic, where 30 to 50% of one ovary is removed, cut into strips, and cryopreserved. It was initially developed as a treatment for women undergoing gonadotoxic chemotherapy, And in that situation, the strips are then reimplanted for the woman for either hormonal or reproductive reasons. And we know that on average, it works for about 5 years per implantation, but usually you can get multiple implantations from one retrieval process. So far, more than 200 live births have been achieved using this technique, and now more than 6,500 procedures are being performed annually. So it's no longer considered experimental in women at risk of premature ovarian insufficiency. Importantly, as I said, it's a fairly low-risk laparoscopic procedure, so there's a very small risk of complication. And again, in a similar fashion to freezing eggs, the pregnancy rates are largely related to the age at which the tissue is retrieved. So in women under the age of 30, they can expect live birth rates of 41%, or pregnancy rates, sorry. But again, in looking, and then they improve as age advances, they reduce, as age advances. But then if you look at those over the age of 40, again, so far the data suggests that it's not effective, as again, this is too late in those women. One of the many benefits is that women can spontaneously conceive after this process, so they don't always need IVF, so it could even be a more cost-effective treatment option for women. We know that when you remove 30% of an ovary, that it has no impact upon ovarian reserve. And even when you remove an entire ovary, from a hormonal perspective, you generally only go through the menopause on average 1 year earlier than you would expect to, usually with 2 ovaries. There's no impact on spontaneous conception rates. And when looking at cases so far, after a mean storage time of about 9 years, 98% of follicles have been shown to survive. And following reimplantation, the follicular density can be as high as 89%, and up to 98% resume or have improved ovarian function following reimplantation. And again, there's not only the reproductive, so this may well be used for women as a means to restore their reproductive potential. Likewise, it might be used by older women who want to use it to prolong their hormonal ovarian age. And it could also be used for HRT purposes. There are other future strategies, which I won't go into in detail, but there's the use of antioxidants, and then there was a study last week, I think, that was on the use of spermidine in the rodent model, and how that can actually reverse or improve ovarian aging. There's also the use of intra-ovarian injections with either protein-rich plasma or autologous stem cells. And these have been used in women that have gone through the premature ovarian insufficiency and then don't have any eggs to collect for fertility reasons. Following intra-ovarian injection with both of these, there's small data that have shown that the AFC, the AMH can both improve, eggs can be retrieved, and IVF you can end up having live births following these types of strategies. Although at the moment it looks like this is only a short-term benefit, and it doesn't prolong the ovarian function any longer than about 6 months so far. So in summary, in the context of rising age, of first-time motherhood, and the trend of delaying childbearing, optimising ovarian health is essential, not only to optimise the chances of meeting one's reproductive aspirations and reducing the potential psychological sequelae, but also to optimise hormonal health and prolong ovarian hormonal function to reduce those risks associated with a premature menopause. It's important that whilst there are certain fertility preservation options available at the moment, that if women are thinking about this, that they need to do it before it's too late. Thank you very much for your time.
Thank you, Ben. Absolutely fascinating stuff, and unfortunately relevant to probably half the population here. Right, any questions? Yes, loads. Richard, I didn't let you speak earlier. Richard Xiao, and then behind you. Go.
Great talk, thank you for that. With the increasing age of motherhood, is there increasing prevalence of gestational diabetes and also preeclampsia? And what is the impact of that on the health or the long-term longevity of the child? as well as the mother?
Yeah, good question. So yes, the answer is that there is increasing prevalence of these conditions. And there is evidence that it can impact the neonatal outcomes and the long-term health of those children. Also, what requires consideration with these methods of fertility preservation is that even though in normal reproductive years there is this trend, if we use the fertility preservation strategies too much, then it could increase these to much more unacceptable levels. So whilst the eggs and the ovarian tissue retain the reproductive potential of the age at which they were frozen, these obstetric risks are still the same. So if a 44-year-old woman does get pregnant with 34-year-old eggs, her risk of preeclampsia, gestational diabetes, they'll all be the same as a normal 44-year-old lady.
Mm. Yeah. No, that's a very, very important point. There was a question behind, yes?
Yeah, I just wanted to know how accessible are these treatments? I'm thinking more in terms of costs and things. Especially because you said you have to do it before it's too late, so women are trying to say, might not have the resources.
No, exactly. And
can you repeat that for in case?
Yeah. So it's the question was with regards to accessibility and how much each a treatment cycle would cost. So it's not funded by the NHS at the moment. It's begun to be. There's a small number of companies that do fund this type of treatment now, but these are few and far between. The cost for an egg freezing cycle is about £5,000, and the cost for subsequent IVF would be £3,000 or £4,000 when you come back to use your eggs. And then the storage cost is about £300 a year. Depending on age, it's a difficult one because whilst if a woman who's 30 comes to see me and considers it, she has probably a 4 or 5 year period where her reproductive outcomes would be very, very good. And she may well meet someone in that time and spontaneously conceive and then not need treatment. Other times women know that they definitely don't want children before the age of 40 in elite sportswomen, say, or in certain professions. And these are women where it's a very easy decision to cryopreserve eggs as early as possible. There used to be a 10-year storage limit on freezing gametes. That's now not the case. They can be frozen for 55 years for some random reason. I'm not sure why, but anyway. So to answer your question, yeah, it's not accessible to everybody, but yeah, that is the way it is at the moment.
Right. Any more questions? Yes, please.
Regarding the ovarian tissue cryopreservation, you mentioned it's not experimental approach anymore, but it's used for cancer patients who have undergone chemotherapy. Do you think it's available anywhere for women who want to do it for delaying menopause, per se?
Yes.
Would that be possible in the UK? And also, have you looked into how the delay of menopause is related to follicles that secrete estrogen and so on? There are some very interesting studies about germ cell independent lifespan extension after young ovary transplantation into old mice.
I've not looked into the latter part yet, but it's something I'll look into. So at the moment, again, it refers to the accessibility for this treatment. So it is accessible to women for fertility preservation in the context of oncology. For women who would desire it for age-related reproductive decline, it is novel. We are looking at performing it at Lister Fertility Clinic in the short-term future. We're just going through the process of changing the licenses for this because we think that the data is strong enough now to extrapolate it into young, healthy women that want to do this for hormonal reasons, but also for reproductive reasons.
Okay. Now, thank you very much, Ben.